Diabetic ketoacidosis is an acute, life-threatening complication of diabetes mellitus. The diagnosis is based on a triad of findings: hyperglycemia greater than 250 milligrams per deciliter, metabolic acidosis with arterial pH less than 7.3 and serum bicarbonate less than 18 milliequivalents per liter, and ketonemia or ketonuria. Severity is classified as mild with pH between 7.25 and 7.30 and bicarbonate between 15 and 18 milliequivalents per liter, moderate with pH between 7.0 and 7.24, and bicarbonate between 10 and 15 milliequivalents per liter, and severe with pH less than 7.0 and bicarbonate less than 10 milliequivalents per liter. Common precipitants include infection, which is the most common trigger, insulin omission or non-adherence, new-onset diabetes, myocardial infarction, cerebrovascular accident, pancreatitis, and medications such as corticosteroids, thiazide diuretics, and sodium glucose cotransporter 2 inhibitors. The core pathophysiologic problem is an absolute insulin deficiency combined with excess counterregulatory hormones, including glucagon, catecholamines, and cortisol. This imbalance leads to three key metabolic derangements. First, hyperglycemia results from increased hepatic glucose production via gluconeogenesis and glycogenolysis, coupled with decreased peripheral glucose utilization. Second, ketosis occurs because insulin lack activates hormone-sensitive lipase, leading to lipolysis. This releases free fatty acids which undergo hepatic beta oxidation to form ketone bodies, primarily beta-hydroxybutyrate and acetoacetate. Third, metabolic acidosis develops from the accumulation of these keto acids, resulting in a high anion gap metabolic acidosis. Secondary effects include profound osmotic diuresis from hyperglycemia, causing severe dehydration and significant electrolyte losses including sodium, potassium, magnesium, and phosphate. A critical electrolyte paradox is the total body potassium deficit, which is severe at 3 to 5 milliequivalents per kilogram, despite the serum potassium often being normal or even elevated initially due to transcellular shifts driven by acidosis. The clinical presentation includes classic symptoms: polyuria, polydipsia, weight loss over days, nausea and vomiting, abdominal pain which can mimic an acute surgical abdomen, often called a pseudoacute abdomen, and profound lethargy. Physical signs are tachycardia, tachypnea with the characteristic deep, rapid pattern of Kussmaul respirations, hypotension as a late sign, clear signs of dehydration such as dry mucous membranes and poor skin turgor, and a distinctive fruity breath odor from exhaled acetone. The most significant red flag is altered mental status, which can range from confusion to coma. Diagnosis follows the American Diabetes Association criteria, all three of which must be present. First, serum glucose greater than 250 milligrams per deciliter. Second, evidence of metabolic acidosis defined as arterial pH less than 7.3, or venous pH less than 7.25, or serum bicarbonate less than 18 milliequivalents per liter. Third, ketonemia with blood beta-hydroxybutyrate greater than or equal to 3.0 millimoles per liter, or ketonuria. Immediate laboratory evaluation includes bedside tests, point-of-care glucose, urine ketones using the nitroprusside reagent test, and blood ketone measurement, with blood testing being preferred as it specifically detects beta-hydroxybutyrate. Stat laboratory tests should include a basic metabolic panel to calculate the anion gap and the corrected sodium, a venous or arterial blood gas, serum magnesium and phosphate levels, and a complete blood count. Expected findings are a high anion gap metabolic acidosis, with the anion gap typically elevated above 12 and often between 20 and 30 milliequivalents per liter, leukocytosis even in the absence of infection, and prerenal azotemia evidenced by elevated blood urea, nitrogen, and creatinine. The primary differential diagnoses to consider are hyperosmolar hyperglycemic state, lactic acidosis, and alcoholic or starvation ketoacidosis. Management is structured around 4 essential pillars. Pillar 1 is aggressive fluid resuscitation. Within the first hour, administer 0.9% normal saline at a rate of 15 to 20 milliliters per kilogram, approximately 1 to 1.5 liters for an average adult. Subsequently, switch to 0.45% normal saline based on the patient's serum sodium level and clinical status, aiming to replace the total fluid deficit, which is typically 3 to 6 liters. It is crucial to add 5% dextrose to the intravenous fluids when the blood glucose falls to around 200 milligrams per deciliter to prevent hypoglycemia while continuing the insulin infusion. Pillar 2 is continuous intravenous regular insulin therapy. Administer a loading dose of 0.1 unit per kilogram as an intravenous bolus. Immediately begin a continuous maintenance infusion at a rate of 0.1 unit per kilogram per hour. This is prepared by mixing 100 units of regular insulin in 100 milliliters of normal saline, creating a concentration of 1 unit per milliliter. The therapeutic target is a steady glucose decline of 50 to 75 milligrams per deciliter per hour. Transition to subcutaneous insulin by ensuring an overlap of 1 to 2 hours between the discontinuation of the intravenous infusion and the administration of the first subcutaneous dose of a long-acting basal insulin. Pillar 3 is meticulous potassium replacement. The critical and non-negotiable rule is to not initiate insulin therapy if the serum potassium level is below 3.3 milliequivalents per liter, due to the high risk of precipitating life-threatening hypokalemia. The replacement guidelines are as follows. If the serum potassium is less than 3.3, hold insulin and administer 20 to 40 milliequivalents of potassium chloride per hour until the level rises above 3.3. If the serum potassium is between 3.3 and 5.2, add 20 to 30 milliequivalents of potassium chloride to each liter of maintenance intravenous fluid. If the serum potassium is above 5.2, withhold potassium supplementation and recheck the level every 2 hours. Additionally, replace phosphate if the level falls below 1.0 milligrams per deciliter, and replace magnesium if it falls below 1.8 milligrams per deciliter. Pillar 4 is to identify and definitively treat the underlying precipitating cause, such as administering appropriate antibiotics for an infection. Ongoing monitoring requires hourly blood glucose checks, frequent neurological assessments, and basic metabolic panel or venous blood gas analysis every 2 to 4 hours until the patient is stable. Resolution of diabetic ketoacidosis requires that all of the following criteria are met. Blood glucose consistently below 200 milligrams per deciliter, serum bicarbonate level greater than or equal to 18 milliequivalents per liter, venous pH greater than 7.3, anion gap close to 12 milliequivalents per liter or less, and the patient is able to tolerate oral intake. A major and feared complication is cerebral edema, which is treated emergently with intravenous mannitol at a dose of 0.25 to 1 gram per kilogram, or with 3% hypertonic saline. Clinicians must also be aware of euglycemic diabetic ketoacidosis, which is associated with the use of sodium glucose cotransporter 2 inhibitor medications and presents with normal or only mildly elevated blood glucose. Its diagnosis requires a high index of suspicion and confirmation via blood ketone testing. Thank you for watching. Don't forget to like, share, and subscribe.